Hello, thanks for taking the time to join me for a little bit of a discussion about pediatric airway management. My name is Grant Young. I'm the Medical Director of Perioperative Services and Anesthesiology at Children's Hospital in Colorado Springs. In addition to being a pediatric anesthesiologist, pediatric airways are near and dear to my heart, both from my role as an anesthesiologist, but also I've been heavily involved in supporting the trauma program based out of Colorado Springs, as well as doing some education and some teaching for airway learners and for the people that we rely on to support pediatric airways in the field, including our own Children's One flight team. So this is a big topic and there's a lot to discuss, to run through. And so we're going to do our best to get through as much of this as we can, kind of from the very basic to a little bit more advanced. You could have whole courses on just this topic. And so I'm going to do my best to anticipate some questions and kind of work through this as quickly as we can and cover as much ground as we can in the time that we have. This is a little bit of an unusual format, and typically we would like to do this with a little bit of a hands-on component, which is hard to do in this setting, but we've got some videos and some other things to show and lots of pictures, and to try to make this as educational and applicable to you in your setting and in your communities. So with that, we're just going to dive right in and try to cover as much ground as we can in the time that we have. So first off, I have no financial disclosures. We'll talk about some different products and devices and airway support pieces. I have no financial interest related to any of them. All images and videos that we come across are all publicly accessible, either on YouTube or on other sites, and I'll reference a couple of those as we go along. They're useful resources for you going forward. So first, just some learning objectives of kind of what we're going to try to cover in the next, little less than an hour, are just to understand the importance of airway management in the pediatric population. Also, just to identify some of the differences between pediatric and adult airways. And there's some key things that'll be useful for you to take with you after this session is over. There's some basics of airway and breathing assessment, which is a cornerstone that's useful for both kids and adults, but we're going to focus on the pediatric side. And then sort of start to touch on some of the interventions and how to manage some of those airway problems you may come across, and with some very basic things up to things that are a little more advanced and a little bit more invasive. And so let's talk a little bit about why airway management is so important. Most pediatric cardiac arrests are caused by respiratory failure, and this is a big one. And it seems obvious to say that airway management is important in kids, and it's important in adults as well. But respiratory failure is a big keystone of pediatric resuscitation. And just if I flip to the next slide here, what you'll see is when we look at pediatric cardiopulmonary arrests, and this is across the 0 to 18 age range, but a good 80% of them are caused from some respiratory origin and some respiratory failure. Only 10% of those have a cardiac nature, and then 10% are shock, and that can be hemorrhagic shock or hypovolemic shock or even septic shock. So you can have a smaller minority of those. Compared to adults, this is vastly different. Adults will have a largely cardiac etiology to cardiac arrests, and they're prone to atherosclerotic disease and coronary disease, as well as arrhythmias and other sort of congenital and acquired diseases. So this is really why pediatric airways are so important, is because a respiratory failure is usually the harbinger of a cardiac failure, and then you enter into this very scary downward spiral. Anybody who's seen this play out in the field or in a hospital setting, has seen this, where a respiratory failure, a child isn't breathing well, they will desaturate, their pulse ox will desaturate, and then their heart rate sort of follows, and they will become bradycardic, and they can actually arrest just from that. So if you can intervene on the respiratory side early, you can actually prevent most of those cardiac arrests in children. So that's why this is so important and such a high yield topic that we really want to press home and give you some skills to work with. The first thing to touch about is that, the pediatric versus adult airways is that one of the hallmarks is that they are different. And, you'll hear people say over and over that a child is not just a small adult, and that is very much true. And so we really want to touch base on a couple of those things. In looking at that, here's just a couple of those things in looking at a child that are notable in terms of their airway anatomy. And this is where it all sort of starts. And in kids, kids have proportionally large heads compared to their body, and especially relative to an adult. So they have, and especially on the back of the head. So the occiput is large, and we'll show you in just a couple slides coming up how that plays out in airway management. But the mandible and the jaw is thin, it's smaller, it's underdeveloped compared to adults. That doesn't grow until kids start to kind of reach late childhood and into adolescence. The airway itself, the epiglottis that covers the glottic opening and the larynx, is long and floppy and has this kind of omega shape to it. And so it can more easily obstruct the airway in children compared to adults. Kids also, everything is smaller. And so they have these small, narrow nasal passages. They have big tongues, all of which can obstruct their breathing in certain situations. And then the final piece that has to do sort of with advanced airway management and intubations are the larynx sits higher in the neck of a child relative to an adult. And the area below the vocal cords in kids is very narrow. And so you have this narrow subglottis, which can make intubation a little more challenging. And so we're not going to spend too much time dwelling on those finer points of intubation because it's a little bit more advanced than what we're going to try to get through. But all that to say, and if you've ever met a pediatrician, they will tell you over and over that children are not just small adults. And this is just one of those things that we really want to continue to press home with you all. So this slide really is just showing a little bit more of those differences between children and adults. We talked about the nose and the nasopharynx being smaller. It's easily occluded by secretions, and you think of any kid that's gotten a bad cold or a bad sinus infection, and the nasal passages can become so easily obstructed. One of the things, especially in really small kids and infants, is that kids under the age of 1 are regarded as kind of obligate nose breathers. And so when their nose becomes obstructed, they really can struggle. And so that's a key point to sort of start. Kids are also prone to lymphatic tissue hypertrophy. And this is why we see lots of kids that have tonsillectomies and adenoidectomies, but all of that tissue hypertrophy in the nasopharynx can further obstruct breathing. And then some things are sort of obvious, is that the oral cavity is smaller in kids, the tongue is still relatively large. And so when everything is smaller, breathing becomes a little harder, and it takes less to obstruct that and to prevent effective breathing moving forward. And then it makes a few points about that subglottic area and the cricoid and tracheal cartilages being more flexible and easier to collapse. And you'll see a little bit of that in a video coming up just as an example. So another piece is when looking at craniofacial anatomy, we talked a little bit about how the occiput and the posterior part of the head is larger on children compared with adults. And here you see on the left-hand side this progression from an infant skull shape up to an adult size, and the cartoon drawing on the right-hand side really shows that difference. And so you'll see how that plays into positioning and some of the breathing distortions that can provide, just with so much more of their skull and their head area sits posterior to the ear and really has that kind of oblong shape that you'll see the impact of that when you have a child who's laying flat. So And then finally, just one more emphasis on the tongue and the epiglottis, and this will make a little more sense coming up as to why we harp on this and why this is so important. When you have that bigger tongue and that big floppy epiglottis, when you have a child that has that is asleep or that is sedated from medications, or they have nervous system dysfunction, and maybe their Glasgow Coma scale is lower than it should be, or there's some traumatic brain injury or closed head injury that's affecting their mental status. All of that can cause a loss of tone, and with that proportionally larger tongue, and that epiglottis is more prone to flop back and to cause upper airway obstruction. So we're going to talk a little bit first about airway and breathing assessment, and this is kind of the place to start, because in order to fix a problem, you have to first recognize that the problem exists. And when we talk about airway and breathing assessment, really what we're looking at is that you have to recognize what a person has to do in order to be able to support their breathing. And they have to first protect their airway, you have to be able to ventilate, and you have to be able to oxygenate. And those three things they work together, but they are independent, and you can do 1, 2, or 3, or you can fail in individual categories of that. And so we're going to talk a little bit about how to assess each of those. Protecting the airway is pretty easy to assess, and there are some real simple things to do that. When we talk about ventilation is really the physiologic ability of a patient to exchange carbon dioxide and to move that carbon dioxide out of their lungs. And oxygenation is their ability to get oxygen in. And so there are certain processes that can cause problems with one, both, or the other. So, but just keep in mind that through all of these, we're trying to make sure that we've assessed their ability to protect the airway, and are they ventilating, and are they oxygenating, okay? In the goal of airway and breathing management, the three categories is we want you to be able to anticipate respiratory problems, we want you to be able to recognize them, and to intervene on them when you see them. So the first step is an ounce of prevention is worth a pound of cure. And so if you're ready for it and you've anticipated it, then it makes it easier to recognize it. And the sooner you recognize it, the better you can intervene on it. So anticipate, recognize, and intervene. So let's talk about anticipating respiratory problems. So in pediatric patients, and this list sort of applies to adults too, I'll have a little more specifics in a second, but in any of these areas, you should really expect, or you should have a very high level of suspicion that they may have respiratory problems. And that's the age and the size of a kid. So if the child is young, if the child is, if it's a newborn versus it's an 8-year-old, the newborn may have more respiratory compromise or more respiratory issues than somebody who's older. Size goes along with patient body habitus too. People with large BMIs, or people with signs of sleep disordered breathing or obstructed breathing on a good day are more likely to have respiratory problems in a situation where they're injured or they're ill. If you're seeing them because there's a concern for a foreign body in the airway that may be blocking some of that air exchange, that's on the list. Complicating illnesses, these would be, any number of things. This can be anything from poorly controlled diabetes up to asthma, croup, respiratory problems. And, in the current world, we also worry about things like COVID-19 is also a risk in that realm. Facial trauma obviously can cause breathing issues. Depressed mental status and depressed Glasgow Coma scales also likely to cause issues. And then drug-induced respiratory depression. And always remember that this can be both medically driven, and so this can be from things that happened in an ER or EMS in the field, and it can be morphine, it can be Versed, it can be sedatives. It can also be things that they may have gotten into out in the world on their own, and it can be opioid medications that they ingested accidentally or intentionally from a family member, or in little kids, it can certainly be things that are accidental ingestions. It can also be other sort of narcotics, and we see we certainly see some of those at times, and it's something to keep in mind. In the specific pediatric world, this is sort of a whole bigger list of that. And so noisy breathing, a croupy cough, obviously, are signs that there's respiratory problems, or they could be decompensating. Voice changes in a kid, and that can, in an infant that doesn't talk or that's nonverbal, that can even be things such as the parent saying that the cry sounds different, or they sound like they have a high pitched or a squeaky cry that's not normal for them. If they've had feeding issues and they have trouble swallowing and breathing at the same time, those are certainly risks. Congenital syndromes, and I'll touch on that in a second, but there are certain craniofacial syndromes and things that you may see that are at higher risk of respiratory problems. Kids that have had previous surgeries on their face, their head, their neck, if they have small mandibles, or mid-face hypoplasia, which kind of goes along with some of these congenital syndromes, but it's an underdevelopment of the mid-face, which can cause sort of respiratory physiology changes. Macroglossia, just another fancy term for a large tongue, small mouth opening. One of the things that you'll see is unilateral or bilateral microtia, which is congenitally small ears. And so those often go along with some of those congenital syndromes, but there are further airway anatomy issues that go with that. Short thyromental distance, which is the distance between the end of the chin and the hyoid bone underneath, which is a part of that profoundly underdeveloped mandible in some kids. And then kids with high arched palates and limited neck movement are certainly at high risk of respiratory problems if they're not having their best day. When we talk about some of these are a few pictures that we just Google image searched, and some of these came from Open Pediatrics, which is an excellent resource for some of these. The first two pictures that you see here are, these are kids with what's called Pierre-Robin sequence or Pierre-Robin syndrome. And you've noticed, they have a very underdeveloped mandible and a very underdeveloped chin. And the picture in the first child here actually has a tracheostomy because of that, which should be a very big warning sign of difficult respiration and potential problems. The two pictures in the middle are one of the more common things that we see amongst kids, and these are kids with cleft lip and palates, both bilateral and unilateral cleft lip and palates. The airway problems aren't always obvious up front, but they certainly are prone to obstruction, especially if they're asleep or their muscle tone is impaired, or they're very sick from other illnesses, as their tongue can fall upwards into that cleft and can really obstruct all of their breathing if they lose some of that muscle tone. And then finally, on the right-hand side, just as an example, this is a child with what's called Treacher-Collins syndrome, but it has this is what we call one of these mid-face hypoplasia, as is the child on the far right-hand side, which is a syndrome called Cruzon syndrome. But it's that mid-face and the nose and the maxillary area is pretty underdeveloped and isn't as prominent and pushed out. This also has a pretty large tongue. And these would all be things that if you were to come across one of these kids, you should certainly anticipate that respiratory issues could be high on the list of things you're going to need to address. So those are sort of our hallmarks on respiratory issues and things that we want you to be able to be on the lookout for. The next step is just to be able to recognize a respiratory problem when you see it. And the simple way that I always teach this when I work with medical students and I work with paramedics and EMTs is that you can really break this into two categories. And the first category is, is it apnea or is it obstruction? And so we'll talk about each of these as to how do you identify it and what do you do about them. And so apnea is the first one. Apnea is they aren't breathing, and more specifically, they're not even trying to breathe. So this is the complete loss of sensation or drive to breathe. Like we talked about with some of those things to anticipate, there are a lot of reasons why people can be apneic. We certainly see people that have narcotic-induced apnea, morphine, fentanyl, heroin, drug overdoses can certainly do this. Other pharmacology, if people are on muscle relaxers, or certainly if we work in a hospital setting or an emergency department setting, you may occasionally see people who've been given muscle paralytics as part of a procedure, or for airway management, which would be things like rocuronium and succinylcholine. But those can cause apnea. One of the things we see a lot at Children's Hospital is prematurity, and young babies and kids that are born preterm have an underdeveloped central nervous system that hasn't quite finished maturing to the fact that it remembers that you have to breathe all the time, always. And so kids can periodically have apnea of prematurity, where they just periodically will stop breathing and they forget to breathe and need a reminder or need some respiratory support to get through that. Respiratory insufficiency, other drug-induced apnea, which can be other kinds of sedatives, can certainly do it. And it goes on and on. But the important thing about apnea is that if you recognize that they're just not trying to breathe, the answer is pretty simple, is that, great, we just need to breathe and we need to ventilate for them. So we're going to come back to how to intervene on that coming up. But that is the easy thing, is that if you recognize they're not trying, fine, we'll do it ourselves. So that's the first piece. The second piece is upper airway obstruction. And really, this is where the money is, and this is where interventions are also super useful in being able to keep kids from tipping over the edge into that respiratory failure. So when we talk about upper airway obstruction, the hallmark of it is it's really a diminished or absent airflow in the presence of respiratory effort. And this is what distinguishes it from apnea. And so this is a kid's trying to breathe, and there's just something in the way that's not making it easy for them. So they're doing their best and they need some help. When you're listening to a kid with airway obstruction, if you're listening for breath sounds, you have to remember that if they have complete airway obstruction, it's going to be completely silent, because there's no airway movement. And if there's no air moving, there's no noise. So if you hear nothing, that is, but they're visibly trying, that is a complete upper airway obstruction. Partial obstructions, which is much more common, and that's what makes noise. So that's what makes people snore. That's when you can hear inspiratory stridor, which is that inspiratory squeaking sort of struggle as they try to pull a breath in as it squeaks through wherever the obstruction is. And so as people continue to try to breathe with that partial obstruction, and if it's partially or completely obstructed, you do get this distorted paradoxical breathing motion. And I have a video here to sort of show what that looks like, because once you see it, it's pathognomonic for an upper airway obstruction. And this all goes towards just being able to recognize what that is before we get to the intervention part of it. So I'm just going to show this quick little clip. This came from Open Pediatrics, which is a useful resource, and you can certainly Google Open Pediatrics. This video, just as a disclaimer, this was made in an operating room, and this is actually a real patient that they're going to show. And so they make a couple comments, I think, about anesthesia in this, which this is not specific to just anesthesia. You certainly would see this in an emergency department, or as a paramedic in the field, or as a first responder on scene, if that's where this was happening. So,
a patient is working hard to breathe, the accessory muscles of respiration, the sternocleidomastoid and scalene muscles, tends to lift the clavicles and allow fuller expansion of the chest. These muscles become tense and rope-like. Look how the skin over the tracheal notch is sucked inward, an important sign of obstruction. The harder the patient tries to breathe against both upper airway or lower airway obstruction, the more negative pressure is created inside the chest. This pressure differential sucks the soft tissue between ribs and at the sternal notch inward. When the diaphragm descends maximally, it pushes the abdominal contents downward and outward, further decreasing intrathoracic pressure. If the airway is obstructed, no air can enter the chest, and this negative pressure pulls the chest wall inward. A rocking chest motion occurs, with the chest falling and the abdomen rising. This is the opposite of normal inspiratory motion. Other signs of airway obstruction can include poor movement of air in and out of the mouth and nose, nasal flaring, faint or absent breath sounds, head bobbing or grunting, and the inability of the awake patient to phonate. The anesthesia provider opens the airway by pulling up on the jaw, then inserts an oral airway. Look at the difference in chest wall motion now that obstruction is relieved. The chest and often the child's abdomen rise together with inspiration. Breath sounds are heard on auscultation. Air movement returns. When a clear mask is used, this air movement is seen as condensation inside the mask. Another important criterion is the color of skin and mucous membranes. Cyanosis is the bluish coloration of mucous membranes and skin due to deoxygenated hemoglobin in the blood vessels near the skin surface. It occurs when arterial oxygen saturation falls below 85%. The bluish skin color associated with cyanosis is a late and sometimes unreliable sign of hypoxia because ambient lighting, skin pigment, and severe anemia make it hard to see. An oxygen saturation monitor is much more reliable if you have one. The ability to manage airway obstruction and to ventilate the patient with a bag valve mask device are essential skills in patient management. Early intervention can and does prevent problems and improve outcomes.
And so hopefully that was helpful just to be able to see that what that paradoxical chest wall motion looks like and that tracheal tugging. And they make a mention to oral airways and bag mask ventilation, which we'll get to in just a couple minutes here. The caveat I always put on it, and they allude to it, is that we do not ever recommend that you follow cyanosis as really a diagnostic truism, where really what is preferred is a pulse oximetry, and we'll cover that again in a second. So. And just finally, the last little bit about upper airway obstruction in kids is the anatomy pieces that we already touched on. And so that large head, the large tongue, the floppy epiglottis, and the hypertrophy of the adenoids and tonsillar tissue in infants and kids can all create sort of problems. Here you see this little picture of this little baby over on the side. You notice with their large occiput, and when you put a baby flat, their chin touches their chest, and their cute fat little baby necks all get squished down, and you can see here how it kind of compresses the airway. And you'll see a little bit better example of this when we get to some of the intervention pieces coming up. Okay. All right. So all of that to say, now it's time to do some interventions, and this is where we're really going to get into what do you do about it. So you've recognized they're either apneic or they're obstructing and they're trying to breathe, but they're just not quite doing it. They're not ventilating well. They're not oxygenating well. And maybe they are or they are not able to protect their airway based off of their mental status. So what do we do about it? So first, we'll start with where everything should start. We'll start with the basics, and we'll talk about a few little basic interventions. First off, the most basic is suctioning. So if you are evaluating a kid and they have respiratory compromise and they're just not doing well, certainly make sure that their nose is clear, especially in those little babies with the little tiny nasal passages. A soft, flexible suction can be really useful in clearing some of that if they have lots of secretions or lots of goobers that are plugging that up. The oral pharynx also important, and these are things where if there's blood in the airway, there's trauma, there's vomit, those sort of things are all useful to suction that. What I always put on here, and I always want to remind people, is that if a child has a tracheostomy, make sure that you've considered, do you need to do some tracheostomy suctioning? Suctioning the nose in a small child who has a trach is not going to do much for you because you've already bypassed that with the trach. So don't forget the trach if it's there. And it sounds silly, but it's certainly something that we see from time to time. So, when should you consider suctioning somebody? Really, if suction's available, it's pretty benign, it's pretty cheap, and it's it's pretty harmless. So give it a go. The worst thing that happens in most cases is it doesn't help. So you gave it a shot, and that's when you do it. So if it's available, certainly suction it if there's any sign that they have excessive drooling, lots of drainage, secretions in their nose or their mouth, and that can be blood, vomit, or just mucousy secretions from sinusitis or respiratory viruses, those sorts of things. Up next is positioning, and this really gets to that key thing of the anatomical differences between kids and adults. We talked about that large occiput in pediatric patients and in infants, and in that other little picture where you see them laying flat and the chin kind of touches the chest, and you really want to make sure that you're doing everything you can to keep their airway open. And so a really flat pillow, or even easier is a folded blanket or a folded towel, is a super useful thing in an infant, where you can see here in this top picture, you can place it under their back and under their shoulders to raise their body up a little bit so that their head is not tipped forward and their chin is not on their chest. And this is a really good maneuver, in general, especially even if you're worried about a C-spine injury in a small child, is that you can see in that picture that even in that setting, the C-spine is maintained in a neutral position, and actually is probably a better position than if that blanket isn't there to sort of hold their neck there. The other thing you can do is, a rolled up, a shoulder roll, or a small rolled up blanket or piece of clothing, or some washcloths can serve the same purpose. Kind of middle-aged kids in that 3, 4, 5 age range typically are pretty good in a neutral position, just lying flat. There's no pillow under them. The pillow would tend to tip their chin down to their chest and kind of close off their airway. So they tend to be pretty neutral. And then, as you get towards older kids and adults, as the back and the shoulders get bigger, a pillow or a blanket or a small padding under the head actually helps maintain that kind of neutral position. So just something to keep in mind is that you want to make sure they look like they're nice and neutral, and they're not flexing or extending their neck, because that's usually where the airway will be best supported. You'll, in this other little picture, you see a little bit of a chin lift, and we'll talk more about that in just a second. So in positioning, there's a maneuver called the triple airway maneuver, and you're kind of doing 3 things all at the same time. And you're extending the neck, and so you're kind of lifting their chin, tilting their head back a little bit, and you can see how that would kind of open up the airway. And you see in this picture, the fingers here are resting on the mandible of the baby, and this little orange line is drawing along the edge of the mandible, and they're pushing upwards and kind of tilting the head back. An important piece when you do this is that you want to make sure that your fingertips and just the pads of your fingers are just right on the bone itself and not on the soft tissue. In little kids, everything is so small and it's so close together that if you are pushing on or pulling up on the soft tissue, you actually can be compressing the airway with just your fingers. And so if you're on just the bone and you feel the bone of the mandible just under your fingers, you'll make sure that you're not compressing the airway. But you can thrust the jaw a little bit upwards, tilt the chin a little bit back, extend the neck a little bit, and you can open the mouth and kind of make sure the mouth's a little bit open so that there's a way for them to breathe through their mouth or their nose. The caveat we always give on this is that if the patient you are taking care of, if you're at all worried about a C-spine injury, and if it's a traumatic injury, or if there's any concern for a C-spine injury, we'll talk about that here in just the next slide, because that can be a little bit different in terms of what you what you do about that. So real quick, I think I'm going to show you a quick video here just about some of the positioning piece about the flexing the neck. And again, this came from Open Pediatrics, which is an excellent resource to be able to view some of these things. So here we go.
Obstructing the airway out of the way, and typically that's going to be the tongue. Tongue is attached to the jaw. If I can move the jaw forward, then I'm going to be able to unobstruct the airway. And to me, the easiest way to do that is just to put your fingers at the angle of the jaw here and really push straight forward. If you can see that, it's just moving the jaw forward. But since the jaw and the tongue are attached, that's going to move the tongue out of the way. And that really is the motion I'm trying to get. And I will typically use 2 hands to do this. So I'll go like this, right? Now, if I want to maintain that airway, assuming that that's opened up the airway and the baby is breathing better now, then what I want to do is be able to get a mask on. I will take this finger that I'm using here, keep the dislocation of the jaw, slide that around like that, come around with the mask, put that on top, put my thumb on top of the mask, and now I'm really pulling up with this finger and pushing down with this thumb and sort of clamping the airway together like that. And that works pretty well. And I would think most of the time you'd be able to unobstruct the child's airway by doing that. Let's do that one more time. Dislocate the jaw forward or sublux the jaw forward, put my finger underneath there to maintain that, put the mask on top, put my thumb on top of the mask, and go from there.
And that's a useful maneuver to do even if you're not bag mask ventilating a patient. Sometimes if it's just related to their mental status and their sedation and they're just so relaxed that their muscle tone has allowed their tongue and their soft tissue to fall back and obstruct their airway, just that maneuver alone can open up their airway without having to resort to bag mask ventilation. So it certainly is worth a first try.
Point of clarity.
So just back to that caveat about C-spine precautions, and I apologize for the picture here. The picture is not what we would probably want to do in terms of the neck extension, but with a C-spine injury or a concern for an injury, if you certainly haven't been able to rule that out, you still do some of these maneuvers, and you can make sure that the mouth is open and you do the jaw thrust. So while keeping the C-spine in a neutral position, you're just displacing or subluxing that jaw upwards. And so if they're lying flat on a bed or on a table or on a gurney, you would pull it up towards the ceiling to move it anteriorly and forward, which will sort of pull the tongue up, but you do it without rotating the neck or rotating the chin lift. It's a little easier if you're worried about a C-spine injury and they're in a C-collar. That's a good little prompt that you're not going to be able to extend their neck, and the chin lift becomes difficult in a C-collar by design, but you can certainly jaw thrust them and you can open their mouth a little bit to make sure that passageway is open. Moving on to one more basic intervention that is super important is oxygen. And so those last maneuvers are kind of targeted towards ventilation, and oxygen goes hand in hand with that. We get asked a lot on how much oxygen should we put on people, and should we do oxygen or no oxygen, or what, in what form of oxygen should we be doing it? And really, for the most part, in the pediatric population, what I tell people is that if some oxygen is good, more is better. And so, there are very few times when you're going to be sorry that you put oxygen on a patient, or that you put too much oxygen on a patient. And so when considering this, I usually use the rule of thumb that if you ask the question and you're concerned about oxygenation, put some oxygen on, go big, go home. You can always dial it back later. And if they don't need it, you haven't really probably done them any harm. So when picking oxygen, a face mask, oxygen, and whether it's a non-rebreather or just a traditional face mask is perfectly great. You'll get more oxygen with a face mask than you will with a nasal cannula. And certainly with a nasal cannula, you get more than you get with typically kind of blow-by oxygen, which is hard to know how much oxygen you're really giving them. So if you ask the question and somebody tolerates it, I usually say, go for the face mask. Nasal cannulas in older kids can be okay if they're awake, alert, they're, following commands and they're confident they can protect their airway. Nasal cannulas are usually a little bit better tolerated in older kids. Face masks are usually better tolerated in younger kids because they don't have the sensation of something tickling or blowing in their nose. So I usually say slap a face mask on them. We can always de-escalate it later once you sort out what their underlying problem is. So pulse oximetry is obviously super useful, and if it's available, go for it, put it on, and can kind of give you an idea of where it is. Those are also useful numbers and useful things to be able to relay to any referring facility on how much oxygen are they on, what's their oxygen saturation, and what their vitals are. So if you have it, please use it. It's a useful thing, and it certainly is better, and it's a more reliable indicator than skin tone or skin color. Rarely is oxygen contraindicated in kids, and we get this question a fair bit. In the adult population, there's those certain kinds of diseases where oxygen can really tip people over the edge sometimes, and some COPD people, and that is rarely the case in kids. The only caveat or exception to that is a few kids with congenital cardiac diseases, and it's very specific congenital cardiac lesions where high oxygen concentrations can cause their circulation to kind of shift to an unpreferred state. And the easy way to remember this is ask the parents, because the parents of these kids always know, and they'll be able to tell you, oh, their SAT's always 80%. That's where they live. That's what they like. And so, the parents will know. If the parents say, I don't know, I think it's fine, it's probably fine. So, and just remember that hypoxia is usually more dangerous than hypoventilation. And so, if they're not ventilating real great and their CO2 is creeping up, you think that is probably better tolerated for a longer period of time than if their oxygen desaturation continues to kind of crump. So throw some oxygen on, you generally will be glad you did. Moving into a couple other interventions. So bag mask ventilation is obviously kind of the mainstay. And this is so important because bag mask ventilation really will allow you to ventilate somebody and oxygenate somebody really indefinitely. If you can do this, you could do this for hours on end. You may not want to, and we hope you don't ever need to, but this is a super useful skill, and it can be used in the field. It can be used in a paramedic rig, in an ER, in an ICU, all the way to tertiary referral centers as needed. So it's also super cheap, and if you get good at it, this is really a life-saving skill. So the two things to sort of pick is that first we want you to pick the right size mask, and so you'll see these ambu bag masks and these face masks come in different sizes, obviously. And I'm gonna show you one little tidbit here. But so they come from the infant size all the way up to a large adult size. Trying to right size it, as you see in this picture on the right-hand side, is important. You want it to cover the nose and the mouth and go around and kind of cover around the edge of the chin. If it's too large and it covers, the eyes, it can get hard to get a seal around, or certainly if it hangs over the edge of the chin. If it's too small and it doesn't cover all of the mouth or all of the nose, it'll be hard to get a seal and get good ventilation. So when in doubt, try to pick the one that fits just right. Depending on where you are and what your setting is, you may or may not have the exact size in place. And so a cheating little tip that can be helpful is that if you don't have quite the right size, go one size up. And sometimes, so you can see, this is an adult size face mask, but what you can do is that if you flip it around so that the narrow part is over the chin, if you go one size up, this often works very well on kids. If you don't have the exact size, go one size up, turn it around upside down so that the narrow part is over the chin. The larger part is up over the nose and across, maybe even across the eyes if need be. But in emergency, that'll actually work really well. So just a little helpful tip to try if you end up in that situation. So in the other pieces, so you've got the right size mask for the kid. Now we just want you to have the right type of bag. And so there's kind of two kinds of bags you'll see for bag mask ventilation. And the most common type, and what you've probably seen in most settings, and that's the most widely available, is a self-inflating bag. And these come under all sorts of different brand names. And we often refer to them as Ambu bags, which is a brand, but is kind of a general type as well. The reason these are so common and that you see these in most places is that they have the broadest use of application. And so the ability to ventilate a patient is not dependent on the flow of oxygen to the bag. And the reason that we really like these in most settings, and certainly in the field and in referring facilities or sort of EMS or those settings that may not have an endless supply of oxygen available, is that even if you don't have a cylinder of compressed oxygen, you can still ventilate a patient with ambient air with one of these bags. And so oxygen is good, but if you don't have it, you can still ventilate a patient and help them breathe even without it. So when in doubt, I always say pick the self-inflating bag, and that will get the job done until you can get to where you need to be. The other type is a flow inflating bag. Sometimes these are referred to as anesthesia bags. That's what you see here in the lower side. These are, the bag it doesn't pop back open after you squeeze it, and it only reinflates with the flow of oxygen into the bag. So if you are ever in a setting where you run out of oxygen or you don't have access to oxygen, one of these bags will not be useful because you will not be able to ventilate them. And these have a role in certain kinds of kids and certain kinds of cases, some NICU babies and some very small preemies, as well as some kids with asthma and bronchiolitis. And there's maybe a little bit of benefit to a flow inflating bag over a self-inflating. Really, it's if they're having respiratory issues, when in doubt, go with the self-inflating bag, and you probably will be okay. So you've got your mask, you've got your bag. Now let's talk a little bit about how to do that. And we're going to show another little clip here just on how to kind of get a good seal and to do that safely.
With the self-inflating bag, because I think people tend to feel a little bit more comfortable with this at first, the big advantage of this bag is that you don't need a fresh gas source. You can work in simple room air, so that if you're resuscitating someone in a non-clinical area or at a scene or something like that where you don't have an oxygen source, this will still work. And that is a real advantage of this kind of system. Now, how does it work? It's relatively straightforward design, and it's very similar to this non-rebreathing mask in that it has valves and a reservoir bag and that sort of thing, and we'll demonstrate that. It's just the quality of the rubber or the plastic that makes it go up and down like this. And there are valves in here very similar to the valves in the mask. They're one-way valves. When I let go, this valve opens and gas comes into the bag. When I squeeze, this valve closes, this valve opens, and the gas goes to the baby. And then when the baby breathes out, it goes into the room. So it's one-way flow from here to the bag to the child to the room. And therefore you don't have any CO2 rebreathing. So that's one advantage of the system, is that you get valves to prevent that from happening. Now, as I said, it will work fine in room air, so I could ventilate this patient very easily without having to have an oxygen source attached. And that is a really big advantage of this particular system. If you do want to give oxygen, you can attach it. You can attach it right here. I've got a bag that has it already attached. And there's a reservoir here very similar to the reservoir that's on the non-rebreather mask. Okay? So now if I'm ventilating this patient, as long as I do it in a reasonable fashion so that this reservoir bag doesn't completely deflate, I can give close to 100% oxygen, because what happens is the oxygen comes in here, fills up this bag, and the green bag will refill from this bag so that I can be giving a fairly high concentration of oxygen. I can always turn up my oxygen flow to keep this bag full. And if I do that and I squeeze the bag at a reasonable frequency, I'm not going to completely collapse the thing. Now, if I'm bagging more vigorously, and I can certainly do that, I won't be giving much oxygen because the reservoir bag will completely deflate, but I can still ventilate the patient with room air. And that's one of the advantages of the system, is that you can always ventilate with room air, even if you don't have the fresh gas source available. Okay? So, valves in the system, no rebreathing, ability to give oxygen if you do want to do that. What about other features of these bags? Well, they may have what's called a pop-off valve on them. And that's right here, and you can see this particular design is one that just opens and closes. If I'm ventilating the patient and using a lot of pressure, and perhaps a little bit too much pressure, this valve will pop off, and typically they pop off at around 40 or 45 centimeters of water pressure. The reason for that is so that I won't accidentally give the baby a pneumothorax, for example, from using too much pressure. That's an advantage, and it's a potential safety advantage for the baby, but the disadvantage is if I have to use more than 40 or 45 centimeters of water pressure, if I have a baby that has a difficult airway or somebody that's an asthmatic who's particularly tight and needs a lot of pressure to ventilate, the pop-off valve is going to prevent that unless I can defeat it. And this particular sample, I can just put a cap on, and now I can use whatever pressure I need to ventilate the patient, and that's perfectly acceptable. So if your bag has a pop-off valve, you really need to know how to get around it so that in this particular design, it is now popping off, and that's fine. Or I can prevent that by covering it over. Or I can even prevent it just by using my finger, but that gets a little bit awkward, okay? That's the way this particular design works, but there are many, many, many different designs of pop-off valves, and what I suggest is that someday when you have a free moment, get the bag that you might have in your clinical area and play around with it and figure out exactly how that pop-off valve works on that particular design.
Okay. So that's a little bit about the bags and how they work and kind of what to do with them. There's a little bit of a demonstration coming up here as to what that looks like. But moving on real quick, because just to make sure we get as much as we can in here, the less invasive sort of airway adjuncts are the other things that are readily available and are useful. And those are things like an oral airway or a nasal airway. Sometimes you'll hear them called OPAs or NPAs, which would be an oral pharyngeal airway or a nasal pharyngeal airway. The benefit of these are just to sort of bypass some of those anatomical obstructions that we've talked about previously. And what you see on the right-hand side, this picture of these oral airways, is that the oral airway helps to bypass the tongue and that sort of posterior obstruction of that can happen when the tongue falls back into the back of the mouth. So on the top here, what you see is this is a right-sized oral airway. If the oral airway is too large, that big hunking piece of plastic can jam in here and can actually push on the epiglottis and can obstruct the airway. And if it's too small, what you'll see is it doesn't bypass the tongue and doesn't really do what you're hoping for. A nasal pharyngeal airway, a nasal airway does the same thing. The difference being it just bypasses it through the nose, but still would still reach into the back of the throat. What they're showing in that top picture is just how to sort of size an oral airway or a nasal airway, and you kind of go from the nose to the tragus, the middle part of the ear, and that's kind of the length that you would need once you put it in. The big benefit of having an oral airway over a nasal airway is that an oral airway is easy to put in, but it is not well tolerated in people who are awake. So it will cause people to gag, it will cause people to cough and choke usually. And so in people that have diminished GCS and that aren't really responsive or obtunded, an oral airway can be a great resource. The airway passage through them is big, and it's relatively straightforward to put in. A nasopharyngeal airway is well tolerated in adult people. It can be a little uncomfortable getting it put in. It's always a good idea to use lots of KY jelly or Surgilube or lidocaine jelly or something as you put it in, just to help it slide in, because you can cause a little bit of nasal bleeding when you do that, but it won't cause that gagging reflex that you see in oral airways. So just something to keep in mind as you do it and as you gauge the size of it. So we're going to kind of skip past a couple of these little videos because they
if you decide
go over over some of those same pieces. So, and then a little bit more invasive airway adjuncts, and we're going to stop just short of intubation and surgical airway management, which would be a lecture onto its own. But the big thing that we look at in these more invasive airway adjuncts are in the family of supraglottic airways, and these are things like LMAs and the like for those sort of things. And these are useful tools when they're needed for prolonged ventilation support. You know, the way I always think about a laryngeal mask airway is it is like a face mask, only you've shoved it down in the throat, so the throat is going to hold it in place and it frees up your hands. So it's not a truly, you know, secured airway in the same way that a endotracheal tube would be, but it certainly is a little more secure than having to hold a face mask and get a good seal around the face with that. So there are different kinds of these that we'll cover in a second, but you know, sometimes ventilation with a face mask can be difficult, and we talked a little bit about, you know, sizing of it, and if it's hard to get just the right size, or in some of those congenital syndromic kids with unusual face shapes, a face mask can be hard to get a good seal around the face, but a laryngeal mask or a supraglottic airway may slide in and may ventilate them quite nicely. And so it's just another algorithm to kind of think and keep in mind, the back of your mind. They're easy to put in, and I'll show that in a second. The other nice thing about it is that if you have end-tidal CO2 monitoring capability, or even if you're using color change capnography, this will give you just a qualitative idea of, are you ventilating and is there CO2 exchanging in addition to just oxygenation? And some of them have adjustable cuffs. And so when you put it in, if it doesn't quite seal, you may be able to tweak that to really salvage that versus, you know, having to move on to a new option. So in looking at these, here's a couple of options about these. The laryngeal mask airway, or the LMA, is kind of the standard, and they come in all different sizes. And you'll see they come down to, see if there's the one I'm holding up here. This one in my hand is down to kids under less than 5 kilos in weight. So they're usually weight based, but they go all the way up to over 100 kilos in size. The cuff on an LMA is typically inflatable, and so you deflate it to put it in, and then you hook a Luer lock syringe up, and you can actually put, you know, 10, 20 mLs of air in to help seal that off. And iGel is another brand of supraglottic airway. It's a silicone rubbery cuff gel. It does not inflate, and so it is the size that it is. But you drop it in, they typically sit very nicely. They don't twist around in the mouth, and they also are bite proof. And so in older kids and teenagers and people who have teeth, if they awake or they are, you know, trying to bite the tube or bite the LMA, they can't actually occlude the breathing lumen through it. And then these other two are things that are typically seen not in a hospital setting, but in a pre-hospital setting. You may see things like comba tubes or king tubes, and these are different kinds of essentially supraglottic airways, but they're blindly inserted, and there's two balloons on them. But typically, if you blindly insert it, the long end of it's going to go into the esophagus. The shorter end and the bigger cuff that sits higher on it will seal in the supraglottis, and you can ventilate in that area in between. And the hope of that distal balloon is that you can occlude some of the esophagus and maybe prevent gastric contents from coming up into the airway or from air going down into the stomach, and you can kind of direct it, but they can be blindly placed as well. And so, and this is just a real quick little animation about how they're placed, and then we will wrap it up.
Vision, hold the tube between fingers and thumb and insert the mask into the mouth whilst pushing the lower jaw downwards. Advance the mask into the oropharynx with a slight twisting motion to negotiate the tongue and tonsils. The tube tip of the partially
All right, and that just sort of shows you they go in pretty much blindly. A little bit of
The inflated
KY jelly goes a long way on being able to get those to slide over the tongue, but they just drop in, hook it up, and with some CO2, you can tell that it's in the right position. So that is all the time I have. So hopefully that was useful and was kind of a real quick overview of a very big topic. Thank you so much for giving me some of your time and your interest in learning a little bit about this. And also just thank you for what you do in your communities. And, you know, at Children's Hospital, we're always happy to work with our community partners, and we're certainly grateful for the job that you do, and certainly encourage you to reach out to us anytime if you have questions or there's other educational opportunities or things we can do to support you. So thanks very much. Hope this was helpful, and best of luck. Bye-bye.